Hello, everybody, and welcome to the Hughes Clues Final Exam Review. This is part 1B, and I just put the disclaimer there in front of you in case you want to look at it again to get a sense of how you should study for the final exam and some suggestions. So let's keep going with where we left off on 1A, and we were talking about the different shock states and the key characteristics of the different shock states. And then I'm kind of throwing in or jumping into hemodynamics, and that's because hemodynamics and the shock states are kind of linked together, because if you have a shock state, how does the physician or healthcare providers determine what's really going on with the inside of the patient? And of course, if we want to find out about the volume status or whether the heart's pumping very well, we have to do hemodynamic measurements. So I think they're kind of linked. So what are some suggestions to figure out the hemodynamics? Again, look at the values that tell you about the volume status to decide whether the tank is empty. If it is, then fill it. If the tank is full, then empty it. And also try and identify from the hemodynamics configuration what you think is the problem, and then select a drug that will fix that problem. Dr. Reed will only give you one problem at a time. I've been told by multiple students that the final exam hemodynamics configurations are not bad. Again, it is often students' best grade if they put the effort forth and study. I know burnout is strong at the end of the semester, but hang in there, keep going, you can do this. So let's look at what else has to be considered when we talk about hemodynamic principles, and that's not only the values. Again, put the normal values for each of the volumes and the things on your exam sheet, and then also put the drugs. If you have a contractility issue, you're going to give a positive inotrope. Right before you is a listing of all of the positive inotropes. I have put DIG on there. It's very rare that you'll be asked about DIG. It's just not usually given in the critical care setting as an acute medication. It's more of a home drug for when a patient has heart failure. And then again, think about arterial vasoconstriction. If that's present, mostly because of compensation for a low heart output. Remember that in a weak heart, vasoconstriction is or does increase the workload, and so a vasodilator may be indicated. I've got a listing of 3 vasodilators. The A and the V indicates which blood vessel that vasodilator is responsible for, and you can see with nitroprusside, arterial and venous vasodilator, whereas nicardipine is mostly an arterial vasodilator, and nitroglycerin in our course is a venous vasodilator. Yes, the category I did not list on this slide was the vasoconstrictors. Again, go look at the exam sheet or the Hughes Clues hemodynamic worksheet where the medications are all listed. That's page 9 of the hemodynamics worksheet, and you can get a listing of the vasopressors. Again, you get the point. Use these drugs or put these drugs in their categories and in different colors so you can find them very quickly. So let's do a hemodynamic scenario, and then we can try and associate that with a specific shock state. So we've got a patient who was admitted a day ago with a myocardial infarction, and they're complaining of shortness of breath, crackles are present, and there's your hemodynamic data. So a diuretic has just been administered, and which medication may also be initiated. So this is probably one that you might have remembered. This is not new stuff that I've invented, but this is just a re-review. I would recommend that you do all the hemodynamics questions, and if you are getting them right, then you are good to go. Notice that I've X'd off the pulmonary artery systolic pressure. That's dust in our course. But when we look at the pulmonary artery diastolic pressure and the pulmonary artery wedge pressure, these 2 values tell us about the volume on the left side, and they are markedly elevated. So the volume on the left side of the heart is high. Another value that tells us about volume is the central venous pressure. Central venous pressure is the same as saying right atrial pressure. The right atrial pressure is high. It is greater than 12. The volume on the right side is high. And when we see that there is plenty of volume in the body, then we look at the cardiac index and it's low. The cardiac index, which is the cardiac output adjusted for size, should be 2.4, and it's low, it's 2. And so therefore, in the presence of plenty of volume, what should the heart be doing with that volume? Well, its job is to pump it forward, pump blood forward, and when it's not, when there's plenty of volume and blood is not being pumped forward, as evidenced by a poor cardiac output, then we know pretty much in our course that the contractility is poor. So we've already been told that, yes, the volume is high, and if the volume is high or the tank is high, then we need to empty it. So there's your diuretic that's been given, but we need to do a positive inotrope. So we look down at our list of drugs, and we want to pick the drug that is in our box for positive inotropic drugs, and that is dobutamine. So hopefully you came up with this answer also. Dobutamine positive inotropes are given for poor contractility or poor cardiac output. And let's go back to that for one quick second. What would we think about that if it was in a shock state scenario? Well, we know that this is cardiogenic or pump shock or pump failure. Now we move to this next question. We've got a patient that's brought to the ED after sustaining a traumatic injury. The patient's skin is pale and clammy. Cap refill is greater than 3 seconds. So there's your descriptors for signs and symptoms of poor perfusion, which ring, 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 ring should signal to you that this patient is under having a shock state, a poor perfusion state. And then we've got the measurements that are present, which will actually tell us what the problem is. And we can see if we look at the one value or the only value that tells us about the volume status of the patient, we see that the central venous pressure or right atrial pressure is barely in the normal range, but it's low. So we know that it's low, and we want to fill that tank. Fill that tank. We do see the compensatory mechanism here of the elevated heart rate, but it's not a good enough compensatory mechanism to bring that blood pressure in a normal range. So we know that this patient has hypoperfusion or poor perfusion, and therefore this patient's tank needs to be full. So we can give a plasma or volume expander. That is the answer to this question. Now, we can go in our heads one step further and say, well, this is a traumatic injury, so the best plasma expander or the best product that would fill the tank is a blood product, because if the patient is losing blood, well, then we need to refill the tank with blood. If you had no gas in your tank, you wouldn't fill it with oil. You're going to fill it with gas, because that's what keeps that car going. Same thing with blood. You need blood. Patient has to have oxygen carrying capacity, so if they've lost blood, they need to be given blood. Make sure you know about blood transfusions. If you have any questions on the hemodynamic stuff, then just email me. Again, go through the practice questions, the review session practice questions, and you will be golden, good to go, not usually too difficult. Now we're going to go back. We've really addressed hypovolemic shock and cardiogenic shock. Let's go to the other shock state, which is obstructive, our third shock state. Now, obstructive shock is one of those tricky little shock states in which there really are a lot of causes of it. And one cause of obstructive shock is what's known as cardiac tamponade. And if you look at this picture, you can see that in this space here, there should only be a small amount of serous fluid or lymph fluid, whatever you want to call it, but it should be about 50 mils. And this space has a lot of fluid in it, which essentially you can see how your left ventricle here is just squeezed and lacks the ability to fill very adequately and therefore do systole or eject very adequately. Signs and symptoms of cardiac tamponade are narrowed pulse pressure, JVD, and muffled heart tones. That trio of signs and symptoms are known as Beck's triad. So what's the treatment? Well, if the cause is, let's say, an elevated blood urea nitrogen, and that's causing the cardiac tamponade from leakage of fluid, then you got to fix it. So whatever the problem, fix it, and then the patient has the potential to do okay. Other causes of obstructive shock include tension pneumothorax and massive pulmonary embolism, not really topics in our course. Now we're going to move on to the distributive shocks, and within distributive shocks there's three different shock states, and that's septic shock and anaphylactic and neurogenic. So this first one, anaphylactic, is some kind of systemic response to some kind of antigen. In other words, it could be drugs or a pollen or a bee sting, a lot of different topics or a lot of different things can cause an allergic response. This is your summation to the right of the signs and symptoms that can be seen with anaphylactic shock. I think probably the most common sign and symptoms that will clue you in on an exam is wheezing, because you don't have wheezing in any of the other three shock states. So anaphylactic is pretty much wheeze. What's the treatment? Well, of course, airway management is our priority. We would give epinephrine, steroids, antihistamines to counteract the antigen or the problem that's causing the anaphylaxis. Neurogenic shock, another type of distributive shock. So this occurs when there is a problem with the spinal cord, when there's a spinal cord injury. And of course, the hallmark sign and symptom for every distributive shock is vasodilation. And that vasodilation is, of course, with any kind of shock, will activate the sympathetic nervous system, except in neurogenic shock, because with the spinal cord, the sympathetic nervous system can't be reached. And so the sympathetic nervous system is out, and the parasympathetic nervous system rules. And that is the cause for your low heart rate. So you have two things that cause a decreased cardiac output, and that's a very massively vasodilated vascular space, so that's decreased systemic vascular resistance, and then you have a low heart rate, which is also contributing to the low cardiac output, and then you have an inability of the sympathetic nervous system to compensate because that parasympathetic rest and digest system rules. What is the treatment? Well, if the heart rate's low, we want to increase the heart rate, and then we want to counteract the vasodilation by giving vasopressors. So we know what our list of vasopressors are. I've got them for you here. Notice that dopamine is listed in two places as a positive inotrope and as a vasopressor. When you see a drug listed in two places, it means that it's very dose dependent for its action, and that's the thing with dopamine. So because you're not responsible for doses, you just have to think, well, what job is dopamine doing in this scenario? Is it doing either or, vasopressor, or is it a positive inotrope? So you'll just have to read the scenario to figure that one out. Then we talk about sepsis, and we know that for there to be sepsis, there has to be an infection or a suspicion of an infection. So it doesn't have to actually be confirmed. And then we have SIRS. Well, what is SIRS? SIRS are all of these signs and symptoms. And the patient has to have two or more signs and symptoms plus a risk for or an actual infection, and then they have sepsis. And then if they have sepsis and a low blood pressure, now we're on septic shock. So why this long scenario? Because you, the nurse, have to be on the lookout for signs and symptoms of SIRS, and you have to identify to the healthcare provider that, hey, this patient has pneumonia or whatever they have, and now I see that their temp is elevated and their heart rate is 90, or their temp is elevated and their respiratory rate is 36. And so that should signal to a savvy healthcare provider, physician, or nurse practitioner that, yo, this is sepsis, and we need to do a whole bunch of treatments to counteract or prevent septic shock. What are those treatments? Well, we need to give them a lot of fluids. We need to culture anything that moves and then give antibiotics. And antibiotics have to be given very rapidly, within an hour. Some facilities even say 45 minutes, but the bottom line is fluids, antibiotic cultures, and cultures, and then antibiotics. Wham, wham, wham. It's got to be given very quickly so that we prevent septic shock. However, when septic shock does occur, and it is also known as the warm stage of septic shock, then you should be able to identify the key characteristics. Now, why is it there? Well, the reason that the warm stage is what it is because these inflammatory mediators or even the microbe toxins cause all of these signs and symptoms. Again, a lot of information on these slides. I don't want to yap on because for the most part you probably have already gotten this, but pause the recording and look at the slide if you're unsure. These are the things you really do need to get. Again, we know that as far as sepsis go, we want to do the initiation like we just talked. We want to give a lot of fluids. We want to do cultures. We want to give antibiotics. And then if for some reason all of those treatments still cause the patient to either go into the cold stage of sepsis or to stay in the cold stage of sepsis, then we will add the vasoconstrictor because that vasodilation has gone away, and or that vasodilation is causing that patient's blood pressure to be too low, and so we need to vasopress because of a low vasodilation. Let me restate that because evidently my brain's on the downward trend. So let's talk about sepsis. We've got massive vasodilation. If fluids and initiation of antibiotics don't cut it, they progress, they continue to progress. We need to give them vasopressors to get that blood pressure up. We know that a bad MAP is going to cause low perfusion. And there are times when we can't get the blood pressure up with one drug and we have to add 2 or 3 vasopressors to the patient's medication regimen. Again, we have vasoconstriction, we call septic shock maldistributive shock because what you have to think about is even though the big blood vessels are massively vasodilated, the itty bitty little capillaries are constricted, and that's what causes the poor oxygen delivery state. How do you know this? Well, if you have an arterial oxygen concentration, let's say of 100, your venous concentration of oxygen should be much lower. It should be 70 or 65. And if it stays in the 100, then you know what? Oxygen's not getting dropped off at the tissue level. Make sure the hemoglobin and hematocrit are good for any patient that's not just septic but critically ill, because your bone marrow is very tired whenever the patient is ill because it has a lot of jobs to do to crank out WBCs and to do other things whenever patients are sick, and the bone marrow doesn't produce hemoglobin. So patients in the critical care setting are often hemoglobin low, as in they're anemic. Switching gears, we're done with septic and all of the shock states. Now we're moving on to what are the treatment modalities for the dysrhythmias. So let's talk about dysrhythmias in general. Why did you have to learn the dysrhythmia? What's the big deal with your patient having a dysrhythmia? Well, the big deal is that any dysrhythmia can cause a decrease in the cardiac output. How do you know if your patient's cardiac output is low? Well, what does the patient look like? What are those adjectives that are used to describe the patient? Is the patient having chest pain? That is an indication that perhaps the myocardium is not getting enough oxygen because the patient's cardiac output is down. Is the patient short of breath? Is the patient dizzy, indicating that their brain is not getting enough oxygen? Are they diaphoretic? Has the low cardiac output activated the baroreceptors that are in the aorta, and so the sympathetic nervous system's been activated, and that's why they get fight and flight, diaphoretic, cool and clammy. Are they having palpitations or feeling like the rhythm itself is causing them to feel like their heart's beating out of their chest? So again, not every rhythm has to be treated. If the patient appears stable, doesn't seem to be effective, then you can just watch the rhythm in some cases, or you can treat the rhythm but maybe not run down the hallway. But if the patient is symptomatic, then you're going to have to treat and treat quickly. Is the patient hemodynamically unstable? In other words, is the blood pressure low? Do they have altered mental status? Is the oxygen saturation very low? Well, then you've got to not only treat it, but treat it fast, fast, fast. And that treatment fast may need medications or cardioversion or defibrillation. Now, I will remind you about the BLS steps. Hey, are you okay? I need help, and so on. Let's talk about the differences between cardioversion versus defibrillation. But before we talk about the differences, let's talk about the similarity. What does both do? Well, both of them deploy or deliver a shock to the patient, and that shock is kind of like what you do whenever your computer is acting up. A rhythm is acting up, well, we want to stop that rhythm, so let's shock them, stop the whole rhythm, and then hopefully on the reboot, as the heart is recovering from the shock, then the SA node will do what it's supposed to do, will do its job, and generate a normal electrical rhythm. However, if the patient is in an abnormal rhythm that has a pulse, so let's identify which abnormal rhythms have a pulse. Any of the atrial rhythms should and do have a pulse. And then there's one ventricular rhythm, and that's V-tach, that can have a pulse. Any of these rhythms, the atrial rhythms or V-tach with a pulse, must be cardioverted. Patient has a pulse, synchronized cardioversion. Why do we want to synchronize? Well, we don't want the machine to deliver energy on the T wave. The T wave is when the heart is resting or repolarizing, and we don't want that electricity on the T wave because then it can send the heart into an annoyed rhythm, which is known as pulseless V-tach or V-fib. We want that shock to occur when the heart is working during the depolarization. What signals depolarization or the working of the heart, and that's the R wave. Again, if you're still unclear on this, I've got a YouTube video. Don't have to watch the whole thing. Just look at the beginning parts of it. It's very helpful if you haven't had a chance in either your simulation days or your clinic setting to synchronize cardiovert or defib a patient. Now, what is defibrillation? Defibrillation is delivering shock whenever it's convenient for the healthcare provider. In other words, the patient doesn't have a pulse, you don't care, you're not looking at their rhythm, you're just shocking them very, very quickly. So again, another YouTube video if you're so inclined. Now we talk about the rhythms. So let's re-review the rhythms very quickly. And I give you all of the bradycardic or slow rhythms. So these are the plain sinus bradycardia and the AV blocks. That's all of them shown to you in front. Now, if Dr. Reed is specifically asking you what rhythm that slow rhythm is, then you're going to have to stop and figure it out. But if Dr. Reed is saying, here's your patient's rhythm, now fix it, and you see very easily, not very many beats on that strip. That's a slow rhythm, some kind of bradycardia, and here's the treatment. It's all the same. Whether the patient is in a first-degree block, a sinus bradycardia, or any of the blocks, if the patient is symptomatic, the patient needs to be treated. So you can see here, if the patient is symptomatic and the heart rate's slow, that means sinus brady or any of the blocks, there's your treatment recipe. Seems like a lot of information to memorize? Don't do it. Write it down. Notice the trickery. We've got for treatment for all bradycardia / blocks, we give atropine. That's easy. Don't need to know doses, so you just know atropine's your drug, and then you can also give or initiate or get in with the physician to start a pacemaker. Now, there are two drugs that can be given. Notice what they do. They're drips. Why? Why would you give those drips? Because they speed the heart rate up. They're supposed to. And so if these fail, pacemaker doesn't work, atropine doesn't work, then they'll use these as a latch stitch. Now, you don't have to know if you're going to use this first or this second or this first and this second. That's not the thing. The point is to write it all down in case you have one of those, what I call select all that apply. Now, select all that apply look very different in Canvas. They're still there. They're just a list in one question or one answer choice. So you're going to have an answer choice that's going to have 3 options to it. By any other look, that's the same as a select all that apply. You got to look at each option and make sure that the one you pick for a sinus brady, excuse me, a bradycardia or an AV block has atropine, pacemaker, epi drip, or dopamine drip, or 2 out of the 4, or 3 out of the 4. Either way, these are the drugs. Now we look at another rhythm. This is a supraventricular tachycardia. How is Dr. Reed listed on her notes? A narrow QRS. I told you that if the QRS is narrow, that means less than 0.12, then the first name of the patient's rhythm is atrial. We could call this an atrial tachycardia, but it's also called a supraventricular tachycardia. And notice how regular it is. What's the drug of choice? What's the treatment protocol? Notice it here. Adenosine, vagal maneuvers, and then more adenosine, and then some more adenosine. And then if it still doesn't stop, then you can do cardioversion. Synchronized cardioversion. Did I skip one? Yes, I did. Finger was too fat. All right. Then we look at this rhythm. Now, if you look at this and then you look at the previous one, see how regular this atrial tachycardia or SVT is? And then when you look at this one, wow, these QRSs are just kind of all over the place. There's nothing regular about them. So anytime there is a narrow QRS but it's irregular, then I really say that this is the ABCDs. So A is amiodarone. I know it's not listed on this sheet, but it can be given. Then there's beta blockers, cardizem, and synchronized cardioversion for your C's, and then D for digoxin. So what do these drugs do, or how do they work differently? And that's kind of the medication tip here. So there are some medications that are known as antiarrhythmics, as in they can convert the rhythm. They can convert the rhythm to normal sinus rhythm. What are the two in our course? Amiodarone and adenosine. These 2 drugs, they convert the rhythm. And then there's other drugs such as amiodarone, diltiazem, beta blockers, and dig that slow the rhythm down. So I've listed amiodarone twice because amiodarone kind of has 2 personalities. Amiodarone can convert the rhythm, but then in some patients it simply slows the rate down. So again, make sure that you get this, that there are some rhythms that convert, some rhythms that simply slow the rate down, and then some rhythms speed the rate up. So there's your little kind of reminder sheet. Put these in their categories if you want. Now let's look at this rhythm. And you can see, wow, this is super regular. I see a PQRST, PQRST for every single complex. But what happens if in the scenario you were told that this patient with this rhythm did not have a pulse? Now this rhythm becomes pulseless electrical activity. Could pulseless electrical activity look like something else other than sinus rhythm? Yes, it can. It could be sinus bradycardia. It could be sinus tachycardia. It could be atrial fibrillation. It could be supraventricular tach. So in other words, in our course, PEA can be any rhythm that where you are told the patient has no pulse. And these rhythms normally have a pulse. So again, let me restate that. If it is a rhythm that should have a pulse, which is all of the atrial rhythms and all of the sinus rhythms, any rhythm that you see listed in the question where there is no pulse, you don't even have to configure what this is. It is PEA. PEA is a rhythm that should have a pulse, and in your scenario, the individual doesn't have a pulse. Well, you know that if your patient does not have a pulse, they're likely not to be awake and alert. And so therefore you have to follow your BLS. Hey, are you okay? No response. Call for help. Check pulse. Begin compressions. And then once CPR is being given, then that is also your clue that epi has to be given. Every time a person's doing compressions, epi's the drug of choice. Epinephrine, IV push. Epinephrine is linked to CPR. Notice that with pulseless electrical activity, again, we're going to do chest compressions, give oxygen, epinephrine. And then what else does the healthcare team have to consider? The healthcare team has to consider the H's and T's, because what is happening is this individual has a normal rhythm. The rhythm is fine. The problem is the pump action, the mechanical part of the heart. The heart is not beating. And therefore, we've got to consider the causes, because some things, such as what we talked about earlier, a cardiac tamponade, is inhibiting the heart from doing its job of pumping, or there's no volume and the heart just says, forget it, or hypoxia, or acidosis, and so on and so on. So the H's and T's are the cause for the lack of pump power. Now, a lot of students, because you watch Grey's Anatomy or you just automatically think that whenever there's CPR that we should shock the patient, that's what you should do in this scenario. And the answer is no. Let's recall what the whole purpose of shocking is. The purpose of shocking is to stop the rhythm. Your patient's in a decent rhythm. They're in a sinus rhythm or a sinus tach. They're in a decent rhythm. You don't need to stop that rhythm. You need to restart the pump power, and that's not going to be helped with a shock. So we want to give epi because that's going to help the pump power, and we want to treat the causes, or you'll be doing CPR for hours and giving epi until all epi vials are gone. Now, what else is the same treatment scenario? And that's asystole. Yay, this one's easy to identify. Same treatment. Why not shock asystole? Again, why do we shock a patient to begin with? To stop the rhythm, and then hopefully the heart reboots. Well, if your patient's in asystole, there is no rhythm. There is no rhythm to stop. There is no rhythm there. And so therefore, any patient in asystole does not need to be defibrillated. Now we look at this rhythm and we see that you have a very rapid rate, but it's a wide complex from here to here. Now sometimes you're going to see a V-tach scenario, because that's what this is, where the tip of it is upside down. In our course, it doesn't matter whether it's right side up or upside down. The bottom line is if you measure from here to here, that QRS is wide. And I told you that if it's wide, then the first name is ventricular. This is ventricular tachycardia. What's the treatment? Well, ventricular tachycardia is sneaky because it too has three personalities. V-tach can be with a pulse. If it has a pulse, then you're going to give amiodarone. If there is unstable to where there is a pulse but the patient is unstable, then you would synchronize cardioverted. I would also like to point out that PVCs, which means there's 2 or 3 of these beats kind of mixed in with a regular sinus rhythm beat, amiodarone is the drug of choice. So whenever you think of PVCs, amiodarone's your drug. Why? It's an antiarrhythmic. It will convert or suppress the PVCs / lots of PVCs V-tach. Now we have our third face or personality of V-tach, and that's V-tach without a pulse. V-tach without a pulse plus or V-fib, that means we defib V-fib. Patient has no pulse, We do CPR. Anytime there's CPR, we give epinephrine. And of course, because we still have an irregular rhythm, we're going to give amiodarone. Amiodarone is given for any kind of PVC/VTAC and VFib. IO, just to recall, is intraosseous. That means, hey, I can't get an IV in this patient. So a lot of healthcare first responders, your paramedics, will pop a line into the intraosseous, that's in the bone marrow, that's inside the bone, and we can give IV fluids and medications through the intraosseous route. That's just what that IO means. You don't have to know the process, you just have to know that intraosseous is another route. Notice this one little small statement that's down here at the bottom. If your patient, and you will be told that your patient is in torsade de pointe, that is a special kind of weird rhythm, ventricular abnormal rhythm, and magnesium is the drug of choice for that. You won't have to actually identify what it looks like. I hope this recording has been helpful. If you have any questions, please